Hello, I'm Rami Arabo, a second-year internal medicine resident in Ascension St. John Hospital in Detroit, Michigan, presenting a clinical vignette of a patient with severe hypothermia requiring modified ACLS and venous arterial extracorporeal membrane oxygenation VA ECMO. A little bit of a background about hypothermia. It is defined as a core temperature of less than 95 Fahrenheit. And it can be classified as mild, ranging between 90 to 95 Fahrenheit, moderate, between 82 to 90 Fahrenheit, and severe, which is less than 82 Fahrenheit. Hypothermia causes almost 1,500 deaths in the United States annually. Presentation and management differs depending on the severity. And etiologies usually include outdoor cold exposure, which is the case in our patient, also cold water submersion, and medical conditions such as hypothyroidism, sepsis, and medications. Today, we present a case of hypothermia requiring advanced life-saving measures and benefiting from VA ECMO. Presentation and treatment course includes a 40-year-old male who was found down with a core temperature of 77 Fahrenheit. At presentation, the patient was unresponsive, hypothermic, and in PEA arrest. CPR was initiated, and given the patient was unresponsive, lacking gag reflex, he was subsequently intubated. ACLS protocol was initiated. Hypothermia protocol was also initiated, including placement of bilateral chest tubes, warm IV fluid resuscitation, and external warming. The patient did not respond to initial management and developed ventricular fibrillation. For that, patient was given one shock, and he was given also one round of epinephrine, but with no response. Per modified ACLS for hypothermia, CPR was continued by mechanical CPR machine given the expected prolonged CPR. But further ACLS measures were delayed until rewarming was achieved. At that point, patient labs were pertinent for venous pH of 7.01, PCO2 of 76, lactic acid of 11.5, and bicarbonate of 15, creatinine of 1.8, troponin of 1.03, and rhabdomyolysis with a CPK of 66,000. You can see an EKG which was showing ventricular fibrillation, and also a chest X-ray which was showing a right-sided hemothorax, and also it can show the vascular catheters of the VA ECMO and bilateral chest tubes in addition to the endobronchial tube. The patient was taken to the cath lab after being rewarmed, and the VFib was treated by shocking. During that time, catheters were placed, and patient was delivered to the cardiovascular intensive care unit. The patient stayed on VA ECMO for 2 days, in which after that he exhibited a full cardiac and neurological recovery. 1 day after, the patient was extubated, and then he was discharged home walking without assistance. Take-home message is that this case illustrates the importance of early recognition of severe hypothermia, which includes Osborne waves, bradycardia, other lab abnormalities, and also the application of modified ACLS guidelines, which requires rewarming in order for ACLS protocol to achieve goals, and also the benefit of VA ECMO in severe hypothermia. Moreover, national guidelines for the management of hypothermia are needed in order that all patients with severe hypothermia would benefit from VA ECMO. Thank you.